take your seats. The event is about to begin. S'il vous plaît, prendre vos places. L'événement est sur le point de commencer.
Good morning, everyone. How's everybody doing? Okay, you're up now, had your coffee? I'm Nicole Redverse, VP Research here at AFMC, and also Associate Professor at Western University's Schulich School of Medicine and Dentistry. And I'm really honored to welcome you today to the Gairdner Award Lectures. Now, before we begin, in the spirit of truth and reconciliation, the Halifax Convention Center respectfully acknowledges that we are on Mi'kmaq territory, the traditional land of the Mi'kmaq people, and we also acknowledge the peace and friendship treaty signed in this territory and recognize that we are all treaty people. Now, we're excited to be hosting today's Gairdner Award Lectures. These lectures represent the principle and the pinnacle of excellence in global health research, and it's a privilege to have distinguished speakers with us who have made tremendous contributions to improving health outcomes worldwide. At this time, it's my pleasure to introduce Dr. Janet Resant, President and Scientific Director of the Gairdner Foundation, who will be moderating our lectures. Dr. Resant will introduce the session and provide a brief overview of the goals for today. Please join me in welcoming Dr. Janet Resant to the stage.
Thank you, Nicole. Good morning, everyone. Thank you for joining us today. And it's my pleasure to welcome you to the Gairdner Award Lectures. And to tell you a little bit about the Gairdner Awards, let's watch a brief video to tell you some of the excitement associated with our awards program.
Tonight, we celebrate you and your incredible research that inspires us all and is changing the future of medicine. Cheers.
Being a Gairdner Award recipient is a life-changing event. A lot of the program is very inspirational to the next generation of scientists.
Biggest excitement is really sharing what we do with others.
Finding and fueling that passion, I think, is key. As research for most people, it's a long game.
So we have a number of different awards under the Gairdner Award umbrella, and one of the most exciting is the John Dirks Canada Gairdner Global Health Award, which is given for research that has impact on global health more broadly and health inequities around the world. And today, we're going to hear from two former Global Health Award laureates in our lectures this morning. The first one is Dr. Zulfiqar Bhutta, who actually you saw quickly on that video. You can recognize him when he comes to the stage. He's a globally recognized leader in child health research. He wears many hats. He's the Robert Harding Chair of Global Health and Child Health and Policy, co-director of the Sick Kids Center for Global Child Health, and professor, departments of pediatrics, nutritional science, and public health at the University of Toronto, and a close colleague of mine for many years. In a unique joint appointment, he also has the Institute for Global Health and Development at Aga Khan University globally. He is a recognized world leader in global child health research with a focus on improving maternal and child health in low and middle income countries. He's worked extensively on evidence-based interventions to improve outcomes during the critical first 1,000 days of life. He's known for his work in developing effective community-based maternal and newborn care strategies, nutrition, and early childhood development, which have shaped global health policies. He's contributed to many international guidelines and continues to do so today, including WHO's policies on diarrhea, pneumonia, and newborn survival. His work has laid the foundation for Lancet 10 nutritional interventions. He has over 1,500 publications and really is still a major leader in influencing global health policies. Dr. Bhutta received the John Dirks Canada Gairdner Global Health Award in 2022. And in today's lecture, he's going to reflect on the progress made in global child health, the challenges that persist, and how strategies must evolve to meet the needs of today's world and the future. These are themes that we will return to in the discussion session. So for those of you who would like to put a question to either of our speakers, start thinking about them now. You'll get an opportunity to ask questions at the end. We're going to go through the 2 lectures and then have a moderated question session. So please join me and welcome Dr. Bhutta to the stage.
Thank you very much for that generous introduction, Janet, and I'm delighted and humbled to be here this morning, particularly as there are so many young people in the audience. I'm going to take you on a journey, a story as to how progress in global maternal child health has evolved over the last 2.5 decades. And to do that, I want to transport you back to September 2000, when 136 of the world's leaders assembled in New York with one single item agenda: how to make this world a better place for its women and children. This was the Millennium Summit in New York, and you can see in the audience many traditional foes standing shoulder to shoulder together because they were indeed united in a common mission. So in the front row, standing next to Jacques Chrétien, you see Vladimir Putin, you see Jiang Zemin, you see President Clinton, you see the leaders of UK and France. You also see amongst them people who were traditional rebels, Fidel Castro standing in the second row. And you also see, if you pair closely, Yasser Arafat and Ehud Barak, the leaders of Palestine and Israel standing together. What united all of these people at that time in New York was this quest to make the world a better place for its people, particularly for its women and children. This Millennium Summit was the foundational stone for laying the Millennium Development Goals that guided global policy, with an end point of 2015 in mind. And 2 of these 8 Millennium Goals focused on poverty alleviation were to do with child mortality reduction by 2/3 by the year 2015, and maternal mortality reduction by 3/4 in the same time period. Now, the world was turned upside down soon thereafter, as many of you know, with 9/11, and then, with that interruption, the momentum was lost. And about 2 years after the Millennium Summit, which I happened to attend as a young academic, I received a call to join a group of people in the scenic location of Bellagio on the shores of Lake Como. And I've often wondered as to why people want to meet in some of the most beautiful places in the world to actually discuss some of its ugliest problems. But we did meet, and I finally decided to go when Bob Black called me and said, "You have to turn up." And this group that met in Bellagio in early 2002 then produced the very first Lancet series on child survival in 2003. And if anybody ever, as young academics, tells you that scientific outputs don't really matter too much, don't believe them. Because this very first child survival series did actually move mountains. It first gave an impetus to the global movement around countries trying to do something about child survival. And secondly, it provided the empiric evidence for what needed to be done. We produced many things. One of those was this influential infographic. Each dot on this map is a cluster of about 10,000 child deaths. And we delineated where 10 million children were dying under 5 every year, mostly in sub-Saharan Africa and South Asia. But we also highlighted the importance of solutions. So we pointed out that we knew sufficiently from evidence-based interventions to actually save about 2/3 of these preventable child deaths. So what happened after that? So if you then look at progress between 2000 and 2015, we brought child mortality numbers from benchmark baseline figures of about 12 million deaths in children under 5, 10 million in 2000, to a little less than 6 million by the end of 2015. And if you take the global population increase into account, the world actually met the Millennium Development Goal 4 target of reducing child mortality. And we also improved maternal mortality. But in hindsight, nothing was perfect. And if you look back and see where were the blind spots in all of this quest, several things emerge that we didn't have a very clear idea of at the time when we coined all of these indicators. One of those was the whole principle of equity. The reduction in child mortality over the period in question wasn't equal. That much of it was guided, as you can see in this map, by countries like China, countries like Brazil, countries in parts of the Middle East and Eastern Europe. And the person who picked that up immediately after taking charge as the executive director of UNICEF was Tony Lake, who made this observation to his staff when they were crowing about the progress made in child mortality. And he said, to disaggregate the data, and you begin to see that there are differentials and inequities because of questions of race, ethnicity, geography, residence, gender. And he therefore charged UNICEF with a principal focus on reducing inequities in child mortality. And let me illustrate that with an example. So if you look at progress through the lens of what essential interventions for women and children do we have across the world, around the time when the MDG targets were ostensibly being looked at, we look at these Manhattan plots. These are median coverage rates for essential interventions. In each one of these black dots that you see is a country. So as you can see, the median values hide behind them enormous differentials between countries, sometimes 2 to 3 to 4 folds for issues such as reproductive, maternal health, care in and around childbirth, immunizations, management of diseases, and environmental issues. So until you recognize the importance of looking at these differentials and reducing inequities, you can miss the bigger picture. And then we also missed the two extremes of childhood in the MDGs. It wasn't recognized clearly that although there was a progress documented in maternal and child mortality seen by these slopes, that if you looked in parallel at the slope of newborn mortality, deaths in the first 4 weeks of life, these two slopes are completely different. So reduction in newborn mortality had really lagged behind the reduction in child mortality. And that's why by the end of 2015, almost half of all under 5 deaths were in the newborn period. And not just in the first 4 weeks, which is the newborn period. If you again disaggregate the data, you realize that a large proportion of these deaths of newborns and mothers, and something that we don't talk about, stillbirths, were occurring in and around the day of birth. So if you take the first day of life, ostensibly the happiest day in the lives of many families, is also the saddest day in the lives of others, because many of maternal deaths, almost half of all stillbirths, and a big chunk of newborn deaths take place in that time period. Now, I often tell my students the eye does not see what the mind does not know. Now, we didn't know this. I was part of a committee that was looking at some of the indicators in 1999 as a precedent to the Millennium Goals. And we had no idea that so many deaths were clustered at that time. Had we known, we would have put an indicator there around measuring outcomes as well as coverage around childbirth. And then we have missed the other end of child health, which is adolescence. I was a member of the UN Secretary General's Independent Expert Review Group for MDGs, and we realized by 2013 that there was absolutely no mention of adolescence in any of the documents. And there was a reason why they were not mentioned, because many people looked at adolescents as miniature adults. Their global measurement in terms of their health indicators was largely through the lens of reproductive health and reproduction. So girls who were married or giving birth under 18 years of age, disproportionately, as you can see on this graph, the poorest quintiles, they were generally measured through the indicators that we have for adults. We had very little knowledge of what was happening to adolescents. And then we missed the so-called missing middle. We missed the fact that between newborn and under 5 children and adolescents, there's an entire period of school-age children. And we didn't realize until some of us did these sums about 6 years ago that if you look at numbers and mortality, around 1 million deaths actually take place between 5 and 13 years of age. And the important thing to compare with others is that there has been very little change in terms of those numbers over time, because many of them are not related to infectious diseases. They are related to things like accidents, injuries, firearms, and things for which we haven't really had global programs. And then finally, it took a pandemic to tell us that these school-age children matter. And if you look at the impact of school closures on the health and well-being of children, we recognize that there was about a third increase in anxiety disorders and depression in that age group, because we just hadn't realized that this was what would happen with the school closures in that time period. So again, knowing some of these issues is critically important to determining policy, measuring indicators, and determining what you need to do. Now, let me spend a minute or two on early adversity, because what all of this underscores is the importance of looking at these early antecedents of life and outcomes that matter throughout childhood. So we look at poverty. And poverty in many places, friends, has a child's face. Because early poverty, not just poverty of means and access, but also exposure to adversity within households, violence, gender-based violence, at times conflict, really matters too much. And the person, again, who got this right in terms of the dimensions of poverty that we don't at times underscore was Mother Teresa, who said that the greatest poverty was not of being hungry, of not spending money, but the poverty of being unwanted, unloved, and uncared for. And she spent her life devoted to trying to overcome this. But children in particular are very susceptible to this early adversity, because the poorest children born in communities with exposure to this adversity also have the worst outcomes going on. So it really is important to look at that early child period of exposure in the first 2 to 3 years of life. And we've seen this in our analysis. This is data from Cesar Victoria's group working with us on looking at what do you see in terms of socioeconomic deprivation early on in what you see for a range of outcomes here, whether it is stunting, whether it is intellectual development, whether it is premature motherhood. All of those things are much worse amongst the poorest of the poor. And it's important to recognize that this is not just from cross-sectional data, that we know a lot of this from longitudinal studies of birth cohorts, where you track the same people, same families over time. And if you look at this, you find that for a range of outcomes, being born in early adversity tracks you for adverse outcomes over time, such as abnormal growth, such as learning deficits, and importantly, also attained schooling. Now, the worst form of exposure to early adversity is currently children who are growing up in conflict, and at times in polycrisis settings, in the combination of climate change, conflict, and adversity. Now here, the world was confused in terms of numbers. The global burden of disease told us that these numbers were really less than 0.5% contributing to mortality in various sectors, and we thought that this was not correct. And that's one of the reasons why I set up a full consortium about 7 years ago to try and see if we could improve those numbers by better empiric measurement. And lo and behold, what did we find? Both for maternal deaths and for child deaths, take Africa as an example. If you look at both direct and indirect contribution of mortality in relation to conflict in Africa, you can see those geospatial codes here. For mothers as well as children, we estimated that close to around 11 million deaths of mothers and children could be attributed to conflict over the time period of 1995 and 2015. And what we also documented was that it was not just exposure to conflict, it was also the severity of exposure. So if you had prolonged conflict in geographies with insecurity, broken health systems, fragility, and population displacement, that this empiric impact on mortality for children and mothers got significantly worse. And that's extremely important to recognize from a public health perspective in terms of not just interventions that come from a humanitarian angle, but those that look at things that you need to do continued over time as things improve. So to summarize this particular point, early childhood exposure to toxic stress and conflict not only has acute impacts in terms of post-traumatic stress, failure of coping, and violent behaviors, children becoming inured to violence, but it also has intergenerational impacts for which we have had evidence just published a month ago in Science on the epigenetic influence of conflict exposure in families. Now, to many, this may appear like a doom and gloom scenario, and it is challenging. But let's see for a moment what can be done and how can we make a difference, which is exactly what we were confronted with in the Millennium Development Goal period, with limited resources, with not enough physicians, not enough human resource to tackle things. And the question was, can we do something at scale to reduce these inequities? And as Janet pointed out, I took on the challenge of trying to work in community settings with community health workers and programs, largely to see if through this, not task shifting, but task sharing, could we do something to reduce these gaps? And we spent a lot of time on not only collating and analyzing the evidence, but also in generating the evidence to indicate how things could change. And these were done both through systematic reviews and also through lived experience analysis with the World Health Organization of what these community health workers could accomplish. And I'm only going to show you one impact slide around the most difficult area that I pointed out about could community health workers and programs impact newborn mortality, as an example, which is such a big challenge. And yes, lo and behold, if you look at the overall evidence, this analysis has just been finished by Lassie, one of my colleagues in Adelaide, where she's looked at public sector workers and also workers that work in the non-public sector, with the NGO sector, and overall, about a 14 to 25% reduction in newborn mortality at population level. I would take that any time. With around 2 million plus newborn deaths worldwide, that is not trivial. So it can be done. So the big challenge then again confronted us a few years ago was that if you really believe that this evidence works, show it to me at scale, and scale being national level, subnational level, large populations, because many of these trials and assessments are done in smaller population size. So that question was very important, and to answer that, I had to set up with enormous resources and time a very large impact evaluation in my own home country of Pakistan, this so-called New Hope project that just concluded a few months ago was focused on trying to implement strategies through government programs in some of the highest mortality burden districts illustrated on this slide. So 17 million population, not small, and we did not implement it. Our role was evaluation. It was implemented by the government through evidence-informed strategies developed and delivered through the community program. And one of the big challenges in these real-life evaluations is exactly that you are dependent upon what happens naturally, and you can't create an artificial trial environment. So lo and behold, in this very area was the area where we had floods in 2022, which displaced 30 million people and impacted a lot of the health services, interrupted them for months at end. So in that real-life scenario, what were we able to see through this community-based outreach program? So first is the coverage of essential interventions went up significantly over this period of time with the same program that at base was only covering about 20, 30% of the population. Remember, this is through the government program, no additional resources or human resource was put in. It is just doing things better in a more focused manner. The big question was, did it make a difference on mortality that I've said was so intransigent to change? And the answer is yes. That contrary to the systematic reviews, what you actually saw on the ground in this real health system is a 27 to 36% reduction in newborn perinatal mortality, stillbirths. And if you compare this with the average change that has taken place, secular trends in the rest of the country, it's about 2 or 3 folds higher in these districts, perhaps because you were starting with such a high base level. And you can begin to visualize how this was still work incomplete, because if you look at the inequity in differentials as one of the basic parameter, this is one district where if you look at the distribution of mortality through these geospatial maps, you see that even within a single district, leave alone a province or a country, there are enormous differentials in terms of pockets of mortality. You see in this particular district, I believe this is Badin, as to how things changed with the floods, that you had significant worsening post-floods for a period of 8 to 12 months. And then you also see how people were able to overcome this within the program by the end of the project. So, if you put your mind to it, it can be accomplished through existing resources and through these community outreach programs. The next big question was, great, well, I mean, you've done it. Can you do it in the real situations that you're talking about, conflict, insecurity, and difficult fragility settings? And the one example here is really the border areas of Pakistan and Afghanistan, where there's a lot of insecurity, a lot of conflict, population displacement. And the big challenge here was, how do you get immunizations to children? How do you reduce the gap in terms of reducing the percentage of unimmunized children, or what we call zero-dose children? And this particular strategy also involved a similar model of working through community outreach workers, lady health workers, and you will note that these health workers worked in tandem with the vaccination system, with whatever resources were available, and with vaccinators who did not come in fancy cars or in fancy vehicles, but worked on the ground with people in the same strategy. And the one outcome slide that I want to show you is really what happened to the number of zero-dose or totally unimmunized children over this period of time in these three regions, 2 provinces and 1 region. And you will see that by the end of the project, not only were the total numbers of unimmunized children reduced significantly, but the gap between the various socioeconomic quintiles also reduced. So we're also able to see a reduction in inequities. So let me now, in the final few minutes, talk about how do we build a future of hope? Because the world has moved on from the Millennium Development Goals to the Sustainable Development Goals. These 17 goals have been signed and agreed upon by every country in the world, not just low and middle income countries. And they include all the health and health-related goals that you see here, not just health as the goal 3, but the importance of focus on gender inequities, importance of focusing on food insecurity, climate, environment, health systems, and adolescence. To address this, I assembled a group in September 2019 in the same setting that we started our journey on, in Bellagio. I brought this group together. Some of them were the same, but many were young people, fresh, who were focusing on these issues. And we produced, despite the fact that a few months later the world came to a standstill with COVID, that over the next 2-3 years, we produced this series on how do you optimize child health across the first 2 decades. What strategies are needed to put interventions in place to reduce the impact of early life poverty on outcomes? Do we have the evidence of what strategies can be implemented? And how can they be implemented both within and outside of the health sector, looking at adjacent social sectors? And we adopted what is called the Nurturing Care Framework. We'd made the case that to address health and well-being of children, you needed to look beyond just the health sector. Look at education, safety, security, optimized nutrition, and also the importance of climate and environment. And we made 8 recommendations that I'm going to share with you now as to what countries need to do. The first basic recommendation is step out of the silos of health only and look at a life course perspective, which means people involved in health, education, social protection, environment need to sit together to see what can be done for families and communities together. And then look at what are the best buys, what are the effective interventions at various age bands that matter, and how can they be tied together? So people just don't look at under 5 children from the lens of the health system and then forget that they have to move into a school system. So health system needs to talk to the education system, school nutrition, protection, and they all need to be based on the best evidence. Multi-sectoral strategies that work, and how can they be implemented in environments and circumstances where you do need complex adaptation. So context matters. And some of these contextual applications of these interventions are what we are working on right now, is how can you do this in conflict and polycrisis settings, climate change, conflict, migration. We talked about enabling environment, but we made a point that I'd be very happy to address in the discussion. How do we make sure that countries have ownership, that they're not dependent entirely on donor assistance, that this is a strategy and a guidance that countries need to bring themselves for owning their programs, leading their programs, and ensuring sustainability. And the last set was that we need to have an equity focus, that it has to, irrespective of where you are, in Africa, Asia, Latin America, or indeed in a high-income setting like Canada or North America, that you have to have equity as a focus. Now, we are facing a challenge right now where EDI is being scrubbed off all documents, but it's not going to go away. And sooner or later, people will have to realize that unless you reach the most impoverished, the marginalized people who are systemically ignored, that you will miss the targets. So let me finish with a few final reflections. First of all, we have a job to do. It's an unfinished business in terms of moving from the MDGs to the SDGs, but we have the knowledge and tools to make a difference. And the political will is what is needed to do the following. First of all, invest early. Invest equitably on interventions that will reach the most marginalized. Invest with a focus on smart investments, best buys, value for money. And you do so now. There is no time to waste. And we do so in all countries of the world. So remember, although I've talked about this in the global context, the principles of global health are everywhere. I'm speaking to you today in Halifax, Canada. You must recognize that some of the greatest inequities in child health and development are in North America. And therefore, I want to finish by just quoting from my friend Jeff Copland's definition of global health as to what does global health mean. And he says that this is an area of study, scholarship, and practice that places a priority on improving health and achieving health equity for all people worldwide, not just overseas or in Africa or in Asia, but right under our nose. Thank you very much for your attention, and I hope that we can answer questions.
Thank you very much, Dr. Bhutta, for, as ever, an inspiring talk, which I'm sure will cause and generate discussion amongst the group today, because clearly this is a challenge for all of us to take on in the world ahead. I'm now going to introduce our next speaker, who is Dr. José Belizán. He's a leading expert in maternal and child health, focusing on hypertensive disorders during pregnancy. He's an obstetrician. He holds advanced degrees from Salvador University in Buenos Aires and Rosario University. Currently, he's professor at the School of Medicine at the University of Rosario in Argentina and principal investigator at the Institute for Clinical Effectiveness in Argentina. He's also an associate professor at Tulane University and the University of North Carolina. And his groundbreaking work, which he's going to tell you about, began with an observation in Guatemala in indigenous populations, leading to studies that actually shaped global policy on the prevention of hypertension during pregnancy. He has over 290 publications in prestigious journals, and again, his research influences international health practices. Dr. Belizán received the John Dirks Canada Gairdner Global Health Award in 2023, the year after Dr. Bhutta. And so in today's lecture, he's going to share the journey of his research from the initial observation to the implementation of a population-level intervention that significantly improved maternal health worldwide. Please join me in welcoming Dr. José Belizán.
everybody. It's an honor to be here. Thank you, Janet. Thank you, Zulfi, for your presentation. Yes, as Janet said, I am from Argentina and Latin America, and my main work was done in Latin America. So I'm going to speak about our studies of calcium for preventing hypertension during pregnancy, the research journey from observation to population-level implementation. My mother tongue is Spanish, so my pronunciation in English is not very good, but I'll try to do it the best I can. As Janet said, I am in the School of Medicine in Rosario, in Argentina. Here. Okay, good. No, okay, well, thank you. Don't move? Okay. No te muevas. C'est un plaisir d'être ici. Je parle un peu français aussi. Alors, just a short introduction. You know that hypertensive disorders of pregnancy is hypertension, preeclampsia, and eclampsia is a severe disease that globally there are around 50,000 to 70,000 women who died for hypertensive disorders of pregnancy. So also we can assume that hypertensive disorder of pregnancy precede about 1.5 to 2 million deaths annually. Okay, as you can see, it's a very severe disease, killing mother and newborns. So in my life, I went to work in quite prestigious Institute of Nutrition located in Guatemala City in Central America. And arriving there, I noticed that regardless of the poverty of people, regardless of a low income, poor diet, there are very low incidence of preeclampsia. I said, what's going on here? Why there is such low incidence? Because in Latin America, we are seeing a lot of preeclampsia everywhere we went in Latin America. So there is a peculiarity in Guatemala. In the Mayan indigenous women, you know, the poorest they are, the more depend their diet on corn. And then what they did is the day before going to the mill with the corn, they put the corn in water. And they add to the water lime, chalk. And they left the corn in the water all over the night. And the day after that, they went to the mill. And as I mentioned you, their diet is very low in everything, proteins, calories, whatever, iron, but it's very high on calcium. And this calcium has an excellent absorption. That's the study that was done in the Institute of Nutrition where I belong. I say, could be any relationship between high calcium diet and low preeclampsia? And then in this period of time, there's not internet, I'm talking about 1977. And then we went to the library with papers and data things, and we couldn't find any association in publications between calcium and blood pressure and preeclampsia. We only were able to do, in this table, you will see in the upper middle of the table, poor countries with low calcium intake and very high incidence of preeclampsia. And the low middle, you can see high-income countries with good calcium nutrition and low incidence of preeclampsia. There are two countries that don't belong to these countries. One is Guatemala, and the other one is Ethiopia. And we say, why Guatemala is there? Okay, I already mentioned that. And what's going on in Ethiopia? In Ethiopia, also poor people, the main component of the diet is a grain called TEF, T-E-F, that have a good concentration of calcium. So there we are. And then we try to see, again, I mentioned these two peculiarities, poor people, poor incidence of preeclampsia, and high calcium intake. And the only thing we find in literature, this was this paper published in 1976, saying that person living in village around the banks of the river in Eugenia, calcium content of the river water decrease as the river flows downstream, while blood pressure of the village living along the river increase. That's the only direct observation that, indirect, not so direct observation. Then we decide to test if there is any relationship between calcium intake and blood pressure. And the first study we did was in rats. And then we have two groups of rats. The one on blue are calcium-free diet group. We randomized rats to be in calcium-free group and in, can't see it, in a normal diet. And what we saw after some weeks of being in the different diet, that rats having, in the blue one, no, a calcium-free diet, have higher values of blood pressure in relation to those with a normal diet. That was the first publication of direct relationship between calcium intake and blood pressure. Then we moved to students. There are students in the institute, like you, and then we asked them if they could participate in a trial that we're going to give them 1 gram of calcium per day or a placebo. And what we saw is that those with good calcium intake in red, a supplementation of calcium decreased their blood pressure value significantly in relation to those receiving a placebo. There was a relationship between calcium intake and blood pressure in young people. And we did the same in pregnant women. We give them a supplement of calcium in red and comparison with a control group, and we saw a reduction in blood pressure in those supplemented with calcium. So we were there, we say, always doing research, we say, what is the mechanisms implied in this relationship between calcium intake and blood pressure? And we did mention a hypothesis, and the hypothesis is that low calcium intake increased parathormone levels. And the increase in parathormone levels increase the concentration intracellular calcium. And what this is, intracellular calcium is in vascular smooth muscle, increased muscle reactivity, and increased blood pressure. That was the hypothesis. And then after that, we try to demonstrate, and we work in paratidocytomized rats, rats that the surgical procedure, they took out the parathyroid. And then what we saw is that when rats have not the parathyroid, not parathormone reaction, the blood pressure doesn't increase receiving a low calcium diet. So we were there. We saw the relationship between calcium intake and blood pressure. We have an explanation of the mechanism. And now I go back to Argentina, and we did a randomized control trial. And women, pregnant women, we are randomized to receive a placebo or to calcium, 2 grams of calcium per day. This is double-blind, triple-blind, randomized control trial. And then we collect around 600 women in each group. And then what we saw is, in the last line, we see hypertension or preeclampsia. There was a reduction of 37%, 37% in preeclampsia on women receiving a calcium supplementation. Okay, whenever you researchers find something, they say, okay, could be replicated in other sites, have somebody doing the same. And yes, after that, there are a lot of 27 studies, 18,000 women studied that did the same that we did in the trial that I showed you. And what you can see in the total, there was a 55% reduction on preeclampsia on women having calcium supplementation in comparison to women having a placebo. The author of this literature review, of the Cochrane review, he seems to divide women regarding the basal calcium intake. The calcium intake before pregnancy, the basal calcium intake, and they put women with a high calcium intake and women with low calcium intake. And we can see that women with low calcium intake, the reduction was a strong reduction, 64% reduction of preeclampsia on women supplemented in calcium with a low calcium intake before pregnancy. Furthermore, with the Institute of Mayo from South Africa, we did a study what's going on if we supplement women or if we increase the calcium intake of women before pregnancy and during pregnancy. And we did a trial where women received preconceptional calcium. They show a further reduction of preeclampsia of 34% plus the calcium received during pregnancy. So relationship between calcium intake during and before pregnancy. Also, I would like to mention that the meta-analysis, the Cochrane review, show a reduction of preterm birth in women with calcium supplementation. It's a 24% reduction. Preterm birth now is a major problem worldwide, and the reduction, the possibility to have a reduction with calcium supplementation of 24% will be a great asset in the world. Following that, we have a pleasure that WHO makes recommendations regarding calcium intake and calcium supplementation. You probably know that WHO recommendations involve a lot of reviews, a lot of discussion, experts doing the review, and then when they come with a recommendation, the recommendations are really quite good. And then this is the recommendation they did at the World Health Organization, saying that in areas where the dietary calcium intake is low, calcium supplementation during pregnancy is recommended for the prevention of preeclampsia in all women. That's important. In areas where calcium intake is low, calcium recommendation in all women. And it's a strong recommendation from WHO. As a researcher, we are very pleased that the study we have done finished in a WHO recommendation. You see here the dose is quite high, 1.5 to 2 grams. And recently, there was a non-inferiority trial done in India and Tanzania, 11,000 women in each site, and then they demonstrate that there's not a difference in the effect of preeclampsia, women having 500 milligrams to 1.5 grams. That is very important because a low dose is easy to be administered to women, and also it's easy to be achieved with fortification. So, again, regarding preeclampsia, what we can see here in 30 years, in maternal mortality, a great reduction of maternal mortality by hemorrhage during delivery, a strong reduction. And there is a prevention to do it, oxytocin during delivery, and then they can achieve that reduction. But what happened with number of deaths by preeclampsia? Nothing changed in 30 years. So now the major threat regarding maternal mortality by obstetric cause is the prevention of preeclampsia. So I'm going to go to another thing that we found it. We have the hypothesis what could happen in the fetus during pregnancy if the mother receives a good calcium intake regarding the low calcium intake. And as you remember, I showed you the randomized control trial we did in Argentina. And after that, we decided to follow up the children of these women. And we follow up at 7 years old. And what we find is surprising that children around 7 years old, between 5 and 9 years old, those whose mother received calcium supplementation have a lower chance of have higher values of blood pressure at this age. Then we saw a relationship between maternal calcium intake and their children's blood pressure. There were not too much study doing the same, but fortunately, last year, a peer publication in Ghana, they did the same randomized control trial that I mentioned you, and then they followed the children for 11 years old. It's easy because it's all in the same population, it's in a cluster. And then they found that women whose mother were in supplementation group have lower blood pressure values at 18 years of age. That's very important because probably they are reducing the possibility to having preeclampsia, these women, when they become pregnant. So whenever you see, then they say, okay, we decide to see this effect on the fetus during pregnancy, and we decide to do a study in animals, in rats. And what we see is that 2 weeks before becoming pregnant, there were 3 groups of women in 3 different diets. One group have a double calcium intake, the other group a normal calcium intake, and the other one in low calcium intake. Whenever, after that, we mated, how to say in English? Okay, they stay with a fiancé or married, I don't know. And then they become pregnant, and then after that, all of them was in a normal calcium diet. And we follow them, we follow the progeny until 52 weeks of pregnancy, that is mostly 80 years old in person. That's the relationship, it's a span of life of rats. And we measure blood pressure of this rat. And that's what we find. Surprisingly, the progeny of the children, the progeny of the rats receiving a low calcium diet, in comparison with those receiving a normal calcium diet, there is a difference of 12 milliliters of mercury. 12 milliliters of mercury, that's a lot. Then we demonstrate in animals that in the span of life, this small effect that we saw early in pregnancy, early after pregnancy, goes all the span of their life, showing a higher blood pressure values. Again, inequities in the world. Calcium intake in the world, in women in the world, are very different. And as you can see here, in high-income countries, only 29% of women have low calcium intake, whereas in low and middle-income countries, 82% of women have a low calcium intake. Then that's inequities, disparity in the world regarding this calcium intake. But the other thing that is very important is not only intake, it's also availability of calcium. And it's demonstrated that 60% of the world population do not have the possibility to have a good calcium diet because there are not availability of products with high calcium concentration. So 60% of the world population. So now, following this, in this recommendation from WHO, they say that dietary counseling of all women who are considered pregnancy should promote adequate calcium intake. And in the other, and the second sentence says, food fortification of staple food with calcium may be an important public health intervention. So we totally agree with this, and we're doing some works about fortification of food and also fortification of water. We're working on the possibility to fortify water. And one thing with that is a modeling study, supposing that we fortify water and flour, that's a modeling study, and you can see several countries from high and low income countries, and the 2.5 is the limit whenever you are upper 2.5 grams per day could be dangerous, and in low and middle income countries, very few, probably newer women will have a diet above recommendations. So the possibility to fortify, it's safe. And we're working with water. It's easy to fortify water. And then what we are doing, is to see the threshold taste. When people are perceiving that the water is fortified, different flavor, a different taste, and in bottled water, the threshold is 521 milligrams. So if we fortify water below 500 milligrams, or around 500 milligrams, people are not going to taste differently the water. It's different in pipe water. In pipe water, we need to use calcium chloride, and the threshold is around 166. So we also can fortify pipe water, and the regulation to pipe water is up to 120. We cannot fortify more than that. So that's what we're working now. We're working in the possibility to fortify, to achieve equity among different populations, and to possibility to fortify water or milk. In sum, the observation of an ancient Mayan tradition in Central America led to the hypothesis. Corroboration of the hypothesis led to the discovery of an intervention that can save maternal and baby lives. This intervention would also involve benefits on the progeny. Intervention to increase calcium intake can range from calcium supplementation before and during pregnancy, and the fortification of staple foods like flours, rice, and water fortification. Advances in this intervention should aim to be universally applied to achieve equity, something that Dr. Bhutta mentioned a lot. Okay, that is a summary. We have some constraint, but it's a summary of what we have done and what we are doing now. And we will be pretty pleased to receive your comments, your participation, if you want to join us, because now we are studying in McMaster University the mechanisms, because the mechanisms, how calcium intake could alter the mechanisms of the implantation, because the preeclampsia starts in the implantation period, how we are going to work on mice to see what could be the mechanism why calcium intake before and during pregnancy could improve or could decrease preeclampsia. Okay, thank you so much. Sorry for my English, but I hope you understand what I said. Okay.
So thanks very much, Dr. Belizán. So a different kind of story, but you see the common features here is we have to think about these interventions, not just in our own healthcare systems, but learning from systems around the world. You can actually come up with interventions that have global impact. So over the last 30 years, as you've heard, particularly from Dr. Bhutta's talk, we've seen significant improvements in maternal and child health, but there are many, many critical challenges that remain. Global deaths related to maternal and newborn health and throughout childhood have sort of flatlined really in recent years. And part of that is due to decreased investments in this area. So we're now going to reflect on these challenges, explore how maternal and child health efforts can move forward, and discuss potential solutions to continue to improve health outcomes globally. And at this time, I'd like to introduce the moderator for today's panel, Dr. Eileen Donovan-Wright, who'll guide us through this discussion. Dr. Donovan-Wright is the Associate Dean of Research, the Faculty of Medicine, and a professor in the Department of Pharmacology here at Dalhousie University. Please join me in welcoming her to the stage.
Thank you, Dr. Rossent. And it's my pleasure to welcome people to come to the microphones. I'm blinded by the light right now, but there's a microphone, I believe, in that aisle and in that aisle. Or they can pose questions on the mobile app, and we will see them up at the front. So while we're waiting for people to gather their questions, and I will do my best to see people at the mic, I'm going to start the discussion with a question. So first, thank you for those wonderful talks. That was really, truly wonderful. Given the recent political changes affecting global health research, particularly the role of the United States in US aid, what do you think the top priorities and strategies are for the international community to advance global health goals?
Okay, thank you. I'm sorry, I put something here in my phone. I'm going to read you two sentences that are not mine, are from Richard Horton, the editor of The Lancet. And he says, improving lives is the only end goal and research goal of research, and research is only relevant when it has impact on human lives. And around the focus of research, he said the public health research community needed to sharpen its public voice. Research can describe the reality of lives lived in certain communities. It can identify vulnerable groups, highlight emerging threats, evaluate new interventions, and model the future. Most importantly of all, research can promote a culture of critical thinking. I repeat this. Most importantly of all, research can promote a culture of critical thinking. Where we're living now is a culture. We're living now a culture of, I put in my right hand those people living for money, to earn more and more money and more power, and the people in the left hand trying to help people to have a better life. Solidarity, again, egoism, and then that's what we think we are living now in many countries and in the world. So we are in the left hand, and then we need to work on the fantastic thing to work for health, to give help for people in an equity distribution of health. That's
Thank you. Thank you. Dr. Bhutta.
So I think there are two questions here. One is really the impact of what's happened south of our borders on science in general, science funding in North America, which inevitably will impact on the global science pool. And the other is really the impact on development assistance of the virtually dismantling of USAID. And there, it's not just the US, as many of you know. There are many powers in Europe, United Kingdom, Germany, and of late also Scandinavian countries that have drastically reduced their development assistance budgets. Now, clearly there are several global compacts in the world which are very much resource dependent. I'll give the example of the Global Vaccine Alliance, Gavi, which provides vaccines to the poorest countries, the poorest children of the world, and the deal there is that the vaccines are supplied through Gavi support and countries put the money for implementation for the vaccine programs. That's how we've been able to save so many millions of lives over the last several decades. And just to have a lot of that funding taken away is a huge, huge challenge for that Vaccine Alliance program. So I do think there will be an impact of the removal of PEPFAR, which was an HIV/AIDS treatment in Africa, of removal of vaccine financing, of reduction in humanitarian assistance in some of the poorest countries of the world. But there is also a silver lining to all of this. As I mentioned in my closing comments, for far too long, countries have also got used to extra resources being available without necessarily increasing their own domestic financing for social sector. I mean, South Africa is an example. South Africa is a country which could easily afford to do more for HIV/AIDS treatment for its own population rather than depend upon PEPFAR for its supplies and commodities. family planning services in many parts of the world, particularly for injectables and implants, have been inordinately dependent upon USAID support. So had this been an orderly change, I think people would have been given some chance to see what alternative sources of financing could have been put in place. But it was, and it has been quite sudden, which is very challenging and unfortunate. But as I said, we would like to see more countries, particularly the middle-income countries, the lower, middle-income countries, take more responsibility for the health and well-being of their populations by increasing allocations for health. And just as a final comment, I mean, there are many countries in the world where the spending on health and social sectors is less than 1 to 2% of their GDP, in comparison with spending on defense and many other areas where there is disproportionate amount of money being spent. So there is an opportunity for a readjustment. So I think rather than self-flagellation, doom and gloom, and what's going to happen, this is also a time for the global community working on these issues to reprogram itself to a future where increasingly you would have to do more with less. And you would have to become more efficient and much more smart in terms of where you invest. And that reduction of inequities agenda is a universal agenda.
Thank you. Thank you for that. And I see someone standing at the mic, I believe, so please introduce yourself and ask a question.
Hello, I'm Kristen Patrick. I'm editor-in-chief of the CMAJ. I'm incredibly humbled to have heard both of your presentations today. And I was thinking, it raised many questions for me. I was thinking what would be the most useful question to ask for folks here. You both talked about finding something really important, knowing it was important, and then facing the challenge to scale it up. And I think sometimes having evidence, very compelling evidence, is not always enough. I'm curious how you would say the steps, what you would say the steps are to convincing people with power and money to invest in something that you know in your heart is going to be game-changing.
You go ahead.
No, go ahead. It's your subject.
So I think that's a fantastic question. And it's actually a question that I asked myself many, many decades ago. When I began and established an evidence synthesis group, we very rapidly realized that a synthesis group wasn't enough. Just producing reviews wasn't sufficient. It had to be an evidence synthesis and translation group. And then with translation came the importance of generating the evidence on impact and impact evaluation. So we've done the whole circles. To answer your question, I think the most important thing in convincing people around what works is to convince them that it works in their setting. For large countries, to give you an example of India, India will not scale up any program, rightly so, until the evidence has been generated in their own context. So taking and transplanting something that worked in another continent, for example, into one's own context would require that level of confidence in the findings. So I'll give you one example, since you're the editor of CMAJ, that I think is very germane and relevant to Canada. For the last 15 years that I've been here, I've often wondered why Canada did not scale up many of the strategies that have led to so much change in low and middle income countries on reducing inequities through community outreach workers. We have populations, we have people living, indigenous populations, living in geographies where we are never going to get enough specialists over there, enough physicians over there. Why can't we use the global evidence that exists of bridging some of that gap with participatory community development of those interventions? One of my very first visits when I arrived here, as I said, 15 years ago, was to go and see Roger Strasser's program up in Sudbury. He had started all of that community outreach. It never got scaled up. But what I'm saying is, generating some of that evidence in your own geography with official government participation and support is an essential step for scaling things up.
And I think that is the one element that in many places people don't focus enough on. So I hope that answers your question a little bit.
Thank you. José?
No, following a little bit, you know, after the evidence came, it's a long, long way to implement what the evidence said. No? The example of calcium, it's more than 50 years ago, 40 years ago, there is a demonstration, and then the WHO recommendation, and I said that nothing happened, or very few happened. So it takes a lot of time. I don't have the solution. That's why I'm working on fortification. That's everybody going to receive, because supplementation during pregnancy is not used. So I don't know, I was skeptic. And in the same site, the project was done in Argentina. They don't fortify, they don't supplement women with calcium. So I don't have a reply, but population-based implementation is the way to go forward, no? In the use of evidence-based.
Thank you very much. That's great. Just while the next person's getting to the mic, there is a question online. So Dr. Gilchrist asked, and this is our International Congress on Academic Medicine, so a lot of people thinking about medical education. Given the complexity of the medical school curriculum and the increasing demands of time throughout that curriculum, when, where, or how do you think global health education should be integrated for our new graduates that are coming through?
Everywhere.
I actually agree with that. Where people have spiral curricula, I think global health, and as I've given you the definition of global health,
yes,
I think this question should be placed in the context of health of people everywhere. So the principles of global health, of equity, of reaching marginalized people, of dealing with global solutions, which increasingly are not limited to your geographies. I mean, I talked about child mortality differentials, the highest differentials, some of the highest differentials in child mortality are in North America. And for, you know, considering the GDP per capita income. So some of those lessons are for medical education, undergraduate or graduate training programs everywhere. And there are some global health challenges now, such as environment and climate, which are also universal. So what I would say is that medical curricula need to be designed to at least offer that opportunity for students to learn. In Toronto, some of our most interested students in global health are undergraduate students. We inevitably want to come and spend time in the summer just to try and become part of the solution. They all know what the problem is, and many of these young people want to at least contribute something in a space that is increasingly complex and also challenging for them. So I think curricula should allow that opportunity for young people to learn, and many resources in global health that are now available, MOOCs, self-learning modules, where students can do on their own time without necessarily being evaluated in it.
Thank you.
I don't know if you are familiar with the initiative of Global Burden of Disease, GBD. The Global Burden Initiative is an initiative at the Institute of, and after review of done in 120 countries, and then they define what are the priorities involving in death and disabilities. And then I think the students should access that and to see where the where is, where Canada also, you have the data from Canada, for any country, which is the major impact or major problem in your countries regarding health. Yeah, that's GBD. You put GBD in your computer, you will find that. And there are graphs, fantastic graphs, where you go over there, and then it's something that we have to share with the students.
Wonderful, thank you. We'll go to this microphone first, and then over.
Yeah, for sure. Nicole Redvers, Schulich School of Medicine and Dentistry, Western University. In the context of this question, I do a lot of work in Indigenous health, and I'm glad you brought up the WHO policy on calcium, because here in Canada, Circumpolar health regions tend to be quite underrepresented within global health narratives. And in fact, just north of my home community, Inuit people's traditional diet contains about 20 milligrams of elemental calcium developed through calcium polymorphisms who have developed over thousands of years to adapt to those low situations. So we actually have the case where calcium supplementation or the recommended dietary intakes actually create hypercalcemia conditions and issues both in kids as well as in pregnant women. Yet at the same time, we have higher rates of preeclampsia in Inuit populations that have been more targeted towards the change from sea mammal and fish diets over to regular diets, which is compensating for or overcompensating for the lack of calcium. So, you know, it's a point about this difference between population level data at the global health or even at the national scale and the context specific data where public health recommendations on a large scale will actually do harm in some populations, particularly in Indigenous populations who, again, have adapted to very unique diets depending on the region of the world and, of course, here in Canada. So perhaps maybe just some reflection on how these global recommendations sometimes actually create the unintended consequences, particularly in Indigenous peoples. And it was kind of interesting, of course, that the idea came from Mayan Indigenous peoples, yet again, very different dietary composition comparatively to here in our Arctic regions.
It's a contribution, no?
So it's a smaller subgroup of people that have a different diet that the global recommendation may not apply for.
Yes, the idea is to have information. You have information about the intake in the population we're going to work, could be to everybody or could be to a woman that have low calcium intake, and then to do you can do a diet assessment, individual assessment, and to see, okay, you are okay with calcium, you have milk and milk products, you achieve 1 gram of calcium per day, you don't need to be supplemented. It's going to be individual.
Okay, great.
So, I mean, there are many examples of population level adaptation over time, particularly to unique circumstances. And that's one of the reasons why I think on these global recommendations, there are always caveats in terms of local adaptation. So I would think that if there are populations here where they have adapted over time to very low calcium intakes for, centuries, then you're clearly right that going in with a solution that's designed for universal kind of principles without looking at the unique needs of subsets and populations, I mean, that would be a challenge. And I don't think those guidelines really talk about universal application in all contexts without taking those adaptive things into account. So I mean, there are examples across the nutrition field where people have had challenges even with iodine intakes, which are relatively safe in terms of developing, deficiencies, secondary deficiencies related to suppression, because their overall intake over time was adapted to a level of tolerance and thresholds that clearly are not responsive to supplementation at higher levels. So you're right, but this requires very specific context-specific knowledge of given populations and public health individuals looking at some of those things and pilot testing them before scaling up.
Mm-hmm. Just out of curiosity in this room, by a show of hands, how many people knew that an average recommended intake of calcium will cause hypercalcemia in many Inuit people?
What did he say?
My point.
What did he say? Okay.
Thank you. Let's go to the mic on my left.
Hello, my name is Hassan. I'm a student at Dalhousie University. I really enjoyed the talks today. I'm also of Pakistani descent, so I really enjoyed Dr. Bhutta's talk about the work in Pakistan. I was just curious, based on that kind of experience both of you guys have working with local governments, what are your guys' kind of recommendations to improve communication and collaboration with local governments and institutions so we can better kind of, focus on scientific evidence and kind of implement recommendations from experts in the field and kind of apply that?
Let me take a shot at this since it's a very specific question. So, the question is very important. And it's important because many scientists think that it's not their responsibility to be speaking to policymakers or advocacy or working on implementation or uptake of some of the results of their research. Is someone else's job, and I think that is not correct. Not every scientist has that ability necessarily to work with governments, but you can always collaborate and build partnerships whereby you can get, if you are certain, and if your results and research is meaningful and corroborated, to work with policymakers in terms of uptake. So you don't have the situation that despite all the evidence, Argentina does not have a flood fortification or a water fortification policy. So it does mean that it's not something that's an afterthought when you design public health interventions at scale, the kind of examples I gave you. It has to be in participation with local governments. It has to be in participation with government programs. I can give you an example. In Pakistan, almost 99% of all of my work is with the government programs. And you don't go and work with them without that level of agreement beforehand, that if the results are positive, they will take it upon themselves to scale it up. And in general, it has worked. But you also have to be very clear with them that if things don't work, then they will adjust the program and modify it so that you don't have non-evidence-based policies in it. It is a laborious process. It is time-consuming, expensive, and requires an enormous amount of patience. But it's the kind of work that gives you much better results over time.
Thank you.
Thank you.
No,
it's okay.
That's good. All right, well, I'm going to go to, I think you've been waiting a while. Please step up.
Okay. Thank you for those profound teachings. My question is kind of similar. I'm Aisha, I'm a medical student from Queen's University. So from what I understand, the marginalized are at the margins by design. So when we finally decide, when we invent an innovation, a social innovation that does create impact, how do we make sure that impact is longitudinal and is sustained long after we're gone from there in that local socio-political context? And what is your experience around that?
If you make a change, how is it sustained? How do we make sure that it's a long-lived change?
Wow.
That's a tough question.
What a question. Do you want to answer? No. You? No, I don't have a really an answer to this, no? In our sample, we think that the sample of fortification, we want to see, okay, if we can introduce that, it's going to last forever. I hope so. But I don't know. You know that the only country that have mandatory food fortification with calcium is UK. And the mandatory food fortification in UK start in the Second War, 1942, around 1942. And then it's remained. Every period of time they make evaluation, a hazard going on, and they say, we can interrupt that. If we interrupt that, we're going to have problems in health, money, waste on health, money. Okay, so then something that is introduced in this way and is evaluated, it's important to do it, and this is an example how this fortification improve the health of people for many, many years, more than 40 years. That's an example.
That's a great example.
Mm-hmm.
Dr. Bhutta.
So it's a great question, and it's a question that relates also to the fact that certainly in public health, a lot of these interventions can only have longevity if you work in parallel of ensuring that governments and importantly civic society sees the benefit of those over time. And I'll give you two real examples. Try and reverse national health services in the UK, the NHS, and people will come after you because although it was implemented by one political government at a time, its value is noted by civic society at large. And here in our own geography, despite the fact that there was such opposition to it, the Republican Party, Donald Trump could not reverse Obamacare because it had nonpartisan support. People saw the value and benefit in it. So at the same time as you develop public health policies and interventions, you've got to ensure that there is that political will and acceptance of the value of certain interventions. So you have to work at the same time on the political economy of those interventions. And I'll finish by just giving you an example of the Community Health Workers Program in Pakistan. I'll just take a minute with your permission, Eileen. The program was developed by a woman prime minister, Benazir Bhutto late, who went to Cairo to the population conference in 1992 and came back so impressed with what she had heard that she wanted to do something for the poorest of the poor rural women in Pakistan. And she felt that she could develop a program of volunteers, health volunteers, who could work in places where there were no physicians. She came back and charged, actually, one of my friends, Mubashir Sheikh, with the task of developing that program, gave him an office in the Ministry of Health. 6 months later, he came back with his resignation letter in his hand, asking her to relieve her of this task. Why? Because the people who were most opposed to the creation of these community health workers cadre were actually the Ministry of Health people, who thought that this would promote quackery, that this would do this and that. Yeah. So what did she do? She said, okay, I will take care of this. She didn't fire the Minister of Health. She asked him to move his office lock, stock, and barrel into the Prime Minister's secretariat. And she gave him refuge for the next 1 year while he developed the program. So that's the importance of building that political groundswell of support, not just at the level of government, but also at civic society. And today, in Pakistan, governments have tried over time to roll back that program. And their biggest opposition that they face is from the communities themselves, who see the value of something when they have nothing. So in public health, in global health, many of us bridge that policy, political economy, and engagement with policymakers all the time.
Thank you very much. Just very quickly, we have about a minute left. There's a question on the screen which is very interesting.
That's an easy one.
Yeah.
So, Sunaina, I actually showed you that project, that program, in that polio program, which was that zero-dose vaccination thing. The way to do that is to really work with the communities and community health workers, educate them over time. It's not easy, but it can be done. So for anybody who is opposing immunizations today in North America and elsewhere, the anti-vaxxers, there is no alternative. You're not going to push them out into the Atlantic or the Pacific. There is no alternative except to engage, dialogue, and talk to them. And eventually, people will see the value in investing in the health and well-being of their children.
Thank you very much. I think you've given us a lot to think about, and I think what we will take away is that global health is everywhere. And it's everyone's responsibility to be part of this critically important conversation at all points in our life, if we can summarize my simple summary. I see that we're out of time, but I can imagine that many people will be thinking about how they can take these conversations back and continue. So I think we're going to welcome Janet back up on the Nicole back up on the stage.
Thank you, Dr. Bhutta, Dr. Belizán, Dr. Donovan Wright. Such an insightful and thought-provoking discussion today. Your expertise and dedication to improving maternal and child health worldwide are truly inspiring for many of us. And we deeply appreciate the time that you've taken to share your valuable research and perspectives with us here today. We've gained some essential insights into the ongoing challenges and opportunities for advancing global health. Thank you to everyone as well for attending this session. We hope that you leave today with a greater understanding of some of the critical issues ongoing surrounding maternal and child health and are inspired to contribute to these global efforts in your own way. And we look forward to continuing this conversation and working together towards a healthier future for all mothers and children worldwide. Thank you again, and have a wonderful rest of your day.
Thank you.